to the Flourish podcast with Dr. Toni Engram, where you will hear straight from some of the best practitioners and leaders in wellness on how to take control of your family's spiritual, mental, and physical health, because we are all designed to flourish. Now, as a reminder, this show is for educational and entertainment purposes only. Nothing said on the Flourish podcast should be taken as medical advice. For your own specific medical advice, please always consult with your own healthcare practitioners. All right, everybody. Today we have part 2 of an interview that I did with my mom about breast screening and imaging. My mom's name is Sherri Pyron. She's a global clinical product marketing manager with 12 years of experience in medical ultrasound product development, over 30 years in multi-modality medical imaging in outpatient imaging centers, and as a radiology department head in hospitals. She's a breast cancer survivor for 17 years and a Six Sigma Green Belt. So I'm excited for you to be here for part 2 of our discussion about breast screening, breast imaging. She talks about her own experience as a patient, and I'm just pleased to be able to share information with you. If you're moving protons around, I would suspect that there are other risks involved with MRI.
So I haven't found any studies that state that there's any additional risk outside of the gadolinium injection. But I'm not in the MRI world, so I'm not intimately involved in that. But it is still, as we mentioned earlier, it's balancing that risk benefit.
Sure.
If your doctor tells you that you have very dense breasts and you need another imaging modality, or sometimes, unfortunately, they may say, we've seen something on your mammogram and you need another imaging modality. If it were me, I would say, and I have actually in my life, they can we look at ultrasound prior to going to MRI? MRI is expensive, and it's you are in this big machine, and so I would in my personal
uncomfortable.
I would go to ultrasound first. I would ask to go to ultrasound first. You may have to, as I think you and I have said sometimes, you may have to educate your doctor occasionally. And I think that that's an okay thing.
We've been known to give gentle nudges before.
I feel like I struggle sometimes to keep up with research and looking at studies and things like that. So I know that they can't keep up with everything. And if I have a great article that makes my point for why I would like to have ultrasound first, then I think it's just a nice thing to do to help them understand, oh, look, I have this wonderful article about ABUS, as a screening for dense breasts. Let's try this first before we go into anything more aggressive.
And I think that honestly, it's a good test for your medical provider, because I think oftentimes there is an epidemic of arrogance among all healthcare practitioners, and I'm not immune to that either. It's kind of built in. If we're the type of people who want doctor before our name, then there comes a certain amount of stubbornness and arrogance. So I think if you send your physician an article, if you send them information that you think is imperative to your own care, and if they have the humility to handle that with grace, then you probably have a good provider on your hands. If they don't, and if they get arrogant and start pulling out the don't confuse your Google search for my medical degree mug, then maybe they're not the best practitioner, especially for people like my audience who tend to want to take accountability for their own health and take their health into their own hands.
And like I said, I would hope that they wouldn't be so arrogant that they would, not be. And now, granted, the article that you send them should be a peer reviewed, it needs to be quality, right? You want a peer reviewed article. You don't want something that they're going to say, well, you're looking at this.
I want a newspaper article. Yeah.
Right. So you want to be sure that it's quality information. And that's another thing that I will say as well. There are a couple of websites for women for breast care in general, for women that want to really know and understand and want to help educate themselves and advocate for themselves. And one of them is densebreast.org. That is a wonderful website with great articles about all of the different methods of imaging dense breasts and just breast imaging in general, as well as typical just breast care, right? It's a great website. I would recommend it to many, many people. And I'm recommending it to everybody watching this because it has so much information. Another really good
in the notes too.
Yeah. Oh, perfect. Another really good website that has a lot of good information is called hereforthegirls.org.
Nice. Okay, so densebreasts.org.
Yep.
Breasts plural, I assume.
Mm-hmm.
That'd be funny if it was singular.
Yeah, well, we try not to talk about just one.
And then here for the girls.
Yep.
.org.
Yeah.
That's greatness.
Yeah.
I love it.
Yeah.
Okay, so for basic screening, all Western medicine stuff, we've got mammography is still kind of first line standard of care, gold standard. Ultrasound, it has some really amazing things about it. MRI has some really cool things about it if the risks don't outweigh the benefits in your particular situation.
Right.
Now, you surprised me when you told me that you actually went to, was it an OB, I think? Someone who used thermography in their practice. So, and have you actually had a thermogram of your breast done?
Yes. Yes, I did.
Amazing.
Yes, I did. And so I'm not going to close my mind to anything. Geek.
I like the work.
Yeah. So the thing about thermogram, first of all, I don't know a whole lot about it at this moment, but I know a little bit. The technology has been around for a while, since the 1950s, because there are multiple things in medicine that came out of military devices. So while we don't necessarily, we're not all keen a whole lot on military stuff at times, but the technology that
where a lot of innovation happens.
Yeah, I mean, sometimes you get the good out of the stuff that wasn't necessarily created for good, but we get the good out of it. So the idea behind the thermography is that we know, and I've talked about it a few times already, the increase of blood flow that you get into tumors, right? the amount of blood flow that comes into a tumor and the new vessels that are created by this rapidly growing nasty thing, it will increase the heat, right, in the tumor. That's the sort of body stuff behind this. Because you get all that increase in blood flow, you're going to get an increase in temperature of the tumor. So that's how thermography is looking at the breast. It's looking at the heat. It's using infrared, looking at the elevated heat. So one of the studies that I've seen that was done in 2016 showed that thermography had a comparable sensitivity compared to mammo. The challenge that thermography had was the specificity and the accuracy. Those were lower. Now, like a lot of other technologies, thermography is also adding AI tools to their technology, so that may improve things. And the reason why you think, oh, this would be simple, but there can be other inflammatory processes that can increase the heat. So that's why thermography is not always specific as you would ask for it to be, because there are other inflammatory things that can happen. So that's where it runs into problems. But maybe if the AI tools can help with that, that may be all that then thermography needs. There are AI tools now in mammography that have been around for quite a number of years, and they really are quite valuable. It's used all the time now. AI with mammo, they use it to like triage the mammogram.
Yeah, that's so really interesting.
Awesome.
Makes the radiologist's job faster, I would think.
Well, so it's like a second look. It's like always having another set of eyes, which is wonderful, right? And then ultrasound now has AI, and especially with the ABUS tool that I talked about, there is an AI there that can also triage. And then for both the standard handheld ultrasound as well as the ABUS, we have AI tools that can help classify nodules. You see the nodule, you measure it, the AI tool can help you define, okay, is this suspicious or does this look benign? And then you can save, oh my gosh, so many benign biopsies, that because that's also a problem. They tend to biopsy everything that they see. Women get a little freaked out because, oh my God, I've got this breast mass, and so you can have this second opinion already there without having to run to another doctor, another radiologist or whatever. So AI is at a point right now, to me, being the geek that I am, we are in an inflection point again. We are at this point where the AI tools are beginning to expand the technology so well that we're going to see some big changes, really big changes, I think, in imaging, medical imaging, in the next 4 to 5 years.
That's incredible. It would, I think it would be really exciting. Not only if you can make these imaging tools that do have some risk, if you can make them more efficient to where they can basically be smarter, but also, I mean, if it could do something like increase the specificity of thermography, how amazing would that be? Because as far as we know, there's no risk to thermography at all. It's like a fancy thermometer, basically, measuring heat at different points. so we get a lot of referrals from the Thermography Center of Dallas, and K6 that's in Dallas. And so I wind up looking at a lot of thermograms day after day. And what's interesting is those practitioners will say that, for one, they all agree that incredibly sensitive, not incredibly specific.
Mm-hmm.
But they actually like that, especially for screening when you're doing it once a year, you're doing it fairly often, because what they say, they kind of bring in an Eastern medicine aspect to it, is you can see those imbalances. You can compare those different temperatures to set norms or established norms. And anywhere you can see those imbalances, you can see them hopefully before they're clinical. So not that it necessarily replaces these more traditional Western medicine imaging techniques, but man, what a cool adjunct if you can catch something that's out of balance while it's still correctable.
Yeah.
If you can improve the lymphatic flow, if you can increase your health in other areas, make sure your liver is detoxifying the way that it should be, then holy smokes, if you could catch some of these spots while you can still correct things, then you get the whole shebang.
Yeah, exactly. So let's keep that AI moving forward.
As long as it doesn't, destroy civilization in the process.
Well, we have to
all that good stuff.
Everything is about balance. It's all about the balance.
Even and especially the AI.
Yes, definitely. I like to look at the good parts of where technology goes. That's why it's like, oh, okay, so this came from defense technology that we were using in the military, but now we have these brilliant doctors and brilliant engineers who found the good side of this and
use it for good. That's right.
Yeah. So that part I really love. I think that's really amazing.
For sure. Okay. Fun questions for you.
Yeah.
What do you know now about breast screening that you wish you knew in your 40s?
Yeah. So, as I mentioned earlier, we knew back when I was in my 40s and I was performing mammograms on patients, we knew a lot as far as what we were limited by. We didn't have good answers as to what the solutions were. It would be nice to have known more solutions back then. I do wish that not only myself, but that more people back in those days when I was in my 40s, they didn't want to start screening until you were 50. And remember, I was diagnosed at 48. I wasn't even supposed to start having screening done. I did it early because I just felt that that's what needed to be done. I had to, start my screening early without any kind of reimbursement from my insurance company. Nobody was supporting that other than, the group of medical providers that I had who were supporting me in that. Yeah. Nowadays, fortunately, here in the US, and I won't say that that's globally, but here in the US, fortunately, they have started screening at 40 for women that are high risk. That's what's really important, I think, is to be able to see that you're screening at a younger age. I didn't, when I was diagnosed, there were so many things that were done out there that were like, oh, with this treatment, 5-year survival rate is whatever. And I told my oncologist, my breast oncologist, I said, I don't want to hear 5-year survival rate statistics, because 5 years for me means I'm 53 then.
Yeah.
So I'm like, I want to hear about the options that I have that would give me a normal lifespan. So, I would love to have had more of that information back then. Screening programs, I wish that all of us knew back then that we should have started screening at a younger age.
So related to that, what do you know now about breast health that you wish you knew then?
Well, so, I thought that I knew a good bit about staying healthy when I was younger. And I did try to exercise, and I breastfed my children, and those things I knew were lowering my risk. However, there are things that I know now about lowering my risk that I didn't know then. I did not know then that there was such a substantial link to the amount of beef that you eat and the alcohol that you drink. I felt like as long as I kept my weight under control and didn't do, things to excess, felt like that would be okay. The other thing is just the association of obesity and the increased risk you get from obesity. And of course, at that time, we didn't even know that there was increased risk with highly dense breasts, because that's in my family history. And so we had no real knowledge that breast density was increasing our risk of breast cancer. So those are the things that I know now. Keeping myself healthy, there is still that mind-body connection that, I would never deny the mind-body connection. I still feel that can help. It may not eliminate all things, but it's still very much a part of that whole body health. And I know that that's not necessarily what people would expect to hear from me, but I think there's a lot of us in typical medicine, traditional medical, that really do understand the mind-body thing.
Absolutely. Absolutely. Would you treat your cancer any differently if you were diagnosed today?
Most likely, but that's because there are more choices today. So with immunotherapy, there's a lot more options that are out there.
And options that might have made you feel more comfortable skipping chemo?
Maybe.
Yeah.
Or even maybe the chemo could have been less. But maybe, I don't know if I would have skipped it altogether. But like I said, with the immunotherapies that are out there right now, they're not doing chemo as often.
Yeah.
That's the good part. So if the actual genetics of the tumor, the cellular level of that tumor would have responded to immunotherapy, I absolutely would have gone for that. Chemo is toxic on purpose, of course.
Designed to take you to the brink of death without killing you.
That's exactly right. And there are effects from that are lifelong. And so you have to be aware of that. I knew that because, of being in medicine as long as I have been. I knew that at the time. But at the time there were no real immunotherapy treatments that were options for me. Maybe if I had a different track, I would have gone into some research studies, but I was lucky in that I was caught early. There was no lymph node involvement. So there was no real desire to suggest any kind of research on me. And I understand that it would not have been the right thing to do.
There are immunotherapy options in the United States now, or mostly in other countries?
Oh, in the United States, there are immunotherapy options.
I know I have a couple of patients who have declined chemo and radiation, specifically to go to Mexico. And I'm not I don't know the nuances enough to know what's different about what they're doing in Mexico versus here in the States, or any country for that matter. But I do know there is at least, I think, more acceptance, or at least less regulation of more alternative treatments in other countries, perhaps.
Yeah, it depends on the country. And, of course, being from traditional medicine, I'm always kind of cautious about some of the things that are less regulated. But at the same time, you have to consider all of the options. I don't know as far as specific to Mexico, but I know in most countries with Western medicine, they are using immunotherapy. I know some patients who have had that here in the US. So, I don't think it's completely unheard of. I think you have to, just really, really study what you're doing, and you have to be quite confident in your physicians that are part of your care team, wherever that might be, whatever physician it is, wherever you're going. You have to be completely confident in them. If you don't have that confidence in your physician, then your course of treatment is going to be much more difficult, I think. I think it's really important to
I completely agree.
Yeah.
Because if you don't, I think with my patient base, especially, there's already a distrust, I think, of some aspects of Western medicine. And so somebody who's already distrusting, who then gets a cancer diagnosis and they're scared out of their mind. And the only person who can diagnose that is somebody who's in Western medicine, and they're going to give Western medicine option. I've seen it go very poorly, and the whole process revolves around fear instead of revolving around healing and getting well quickly. And I think anytime a process is mostly motivated by fear, then you really mess with the mind-body connection, and your healing course won't happen the way that it could happen otherwise.
Yes, that's absolutely true. And you can't be afraid to go to multiple people before you decide on what doctor you want. You can't be afraid of that. You have to be able to do that. I don't know if you remember or not, But you went with me, I think, for one visit. I went to more than one breast surgeon. And I had strong opinion. I was strong opinions.
I think the one that you chose was not the one that I liked the best, but you were like, no, I like this one. She seems sharper and I like how she answered my questions, and that's who you went with, which is exactly what you should have done.
Yeah. Yeah. And that's, you have to find that one that you can feel comfortable with. Yeah. And, I had one that wanted to see things for herself in her own ultrasound. And yeah, that one didn't go well. So you have to have that confidence in who you're working with.
Yep, I agree. So knowing that you have been in this field for a couple of years or more, and you have your own personal experience, you've got the experience of several family members who've gone through this process, and I know lots of friends also. You know all the people. You're like me in dentistry, or me in holistic biological dentistry. You know all the people.
Yeah.
If you had a diagnosis today of breast cancer, what country would you go to? What you do? And you can even share names if you have names. Like where would you go and what would you do?
Yeah. So, I have been so lucky in being able to travel globally, and meeting some amazing people doing some amazing work. There are amazing people doing amazing work here. And I've met quite a number of them. And, I would still be here in the US. And one of the reasons why, and I know a lot of people aren't happy with our medical community right now, but we actually are ahead of other countries in implementing a breast cancer screening program, in modifying the age to start our screening program, now in notifying women of their breast density and requiring that information to be given to women. I mean, Lord knows, don't try to save us from the truth. Goodness help us. Right? I mean, and then all of this for me says to me that while it's not perfect, we know it's not perfect, but it is telling me that the medical community here is finding a way to put the patient's well-being in the forefront. Now, is it all about the patient's well-being? No. Of course, we know that it's all about the patient well-being. There is an economic portion of this as well. And what that is actually still good for all of us, though, because the economy portion of this is that when you find a breast cancer extremely early, prior to any kind of spread to the lymph nodes, or if you find it in situ, when it's not even a real mass yet, or if you find it on thermogram, where it's just an increase in blood flow into a specific area, and you can stop it, the economic impact is actually really big, because now you're not going to have to spend a lot. The insurance companies aren't going to have to spend all that money on you for all the treatments and the surgeries. But beyond even the insurance companies, going into as a personal economic thing, you're going to have much less time off from work. You're not going to have to be spending your money on surgery or treatments or whatever might be. If you're having to travel to another country, you're not going to have to spend as much money if you can catch things early. So the screening program does help patients in both ways, as far as finding things early, but also on the economic level. So while the US isn't perfect, I would still stay here, even if my diagnosis was today. There are some, like I said, some great doctors here that are doing some amazing things. I know a few of them even here in the DFW Metroplex. I know a few in Chicago that I wouldn't hesitate to go to if for some reason my doctor in the DFW area wasn't available. I know some in Northern California that I would go to. So there's some really good people doing some really good things. Not all of them are going to be closed-minded. If you decide to do something that's a little less traditional, they'll give you their opinion, and that's what you need. You need to hear the opinions, regardless of whether you agree with it or not. You need to hear the opinions so that you can weigh all your options. So there's some really good things being done in Europe. I met a radiologist in Greece that has been really, really very active with the medical community in the EU countries. She herself is also working to get dense breast notification for EU countries. It hasn't happened yet, but there's some movement there. So she's working very hard to make that happen. And so, there's a lot of people that are doing a lot of really good things.
Well, that is good to hear, that even as many people as you would still feel completely safe and in good hands getting treatment here in the States and even here locally in the Dallas area too.
Yeah, I feel like we're pretty lucky.
Really and truly, not to be an arrogant Texan, but we really do have a lot of really cool healthcare opportunity, whether holistic and allopathic.
Right.
Like on both sides, there's so many great practitioners here. And I'm not sure why there are so many, maybe because we're all so sick. So it's not such a good thing to brag about, but there are amazing practitioners here.
There are. And yeah, I don't know why, but there are, it's a nice area. It's a big area. I'm sure that all of that plays into why we are able to attract some really good practitioners.
Tools, and so therefore good practitioners.
Right. And there's some really good research that is even being done here. So that part's really good. Even when I start looking at a lot of the research that's out there, there's still a lot of nice things that are being done here.
Agree. Well, do you have any parting words of wisdom or anything that you really feel like women should know?
Yeah. So one thing I hadn't talked about yet that I really wanted to talk about is when you do decide to have your screening, and please have some sort of screening. Whatever it might be. Don't
Starting at 40?
Begin at 40. And
Earlier, if you have risk factors?
There's some sort of things that would say if you have high risk factors, you could start at 35. If you're doing a like thermography or breast ultrasound, I would say that would be okay to start at 35. I wouldn't start mammo or MRI that young, because there's just too many things that might be able to hide. Your breasts are still so glandular at that age. But if you have high risk factors, and you can, talk to your doctor, and really I would encourage, like I said, whether it's thermography or ultrasound, those could start at 35, at least as a baseline.
Self-exam even earlier than that, really.
Self-exams should be started. So I don't want to talk about too many sad stories, but I want to say self-exam, you should start when you're 18 at the very latest, and do your self-exams regularly. You learn your own breast. You learn what each thing feels like. You will recognize the changes over your cycle, your monthly cycle. You'll recognize the changes that happen to your breasts and how they feel different when you do your self-exams. Not just that they're tender, because we all know they are, but you learn that different feel as your hormones fluctuate. So when there's a change, you will be the first person that notices the change. And I when I was teaching women how to do their self-exams, I always would tell them, just mark it on the calendar, do it the week after your period's done. Mark it on your calendar after your period is finished, do your self-exam. And it's simple, and don't just feel for lumps. Look for skin changes, any kind of skin pulling in, any dimpling, things like that. Skin changes can indicate a problem too. So start that when you're very young, because it can happen at any age. It's rare in women below 35. It is very rare, but it's not non-existent. So just keep that in mind. When you look for a place to go for a screening, if you're going to go for a screening ultrasound, a screening mammogram, or a screening MRI, you want to look for a place that has a board certified breast radiologist, and it needs to be a facility that is ACR accredited for breast imaging.
Oh, okay. Yeah. What's ACR?
American College of Radiology.
Okay.
And in order to meet the criteria to be ACR accredited, these facilities actually do have to send them images. So they know that they're taking good quality images, both mammogram as well as ultrasound. So look for an ACR accredited facility so that you know.
Say something about the radiologists that they hire as well, or not necessarily?
Typically, an ACR accredited facility is going to have a board certified radiologist, but it never hurts to check and make sure.
Yeah.
Anything's possible out there, right? Yeah. But that's typical of a facility that would go to that, because it's an extra cost for them. It's an extra time and effort for them to be ACR accredited. So what's
more common. Is it more common for them to have that accreditation, or for them not to, if they're like, say, a large imaging center that has multiple locations?
If they really are, if they're a large imaging center that is focused on breast imaging, it's common for them to have ACR accreditation. If they're not focused on breast imaging, if it's just so happens to be one of the things that they do, they may not be.
Okay.
And ask if they have ABUS. Ask if they have that whole breast ultrasound.
Yeah. Okay.
Those are more difficult to find. They are out there, but they're more difficult to find. But those are really good screening tools. They're no risk, and they're not as difficult as a mammogram. We know with mammogram you have the compression, and by the way, I didn't get a chance to say this earlier. The compression in mammogram is how they reduce the depth of the breast so that they can reduce the dosage. Also, when you have dense breasts, compressing that breast will kind of spread the tissue apart. So it's sort of like opening the blinds. You sort of bring things apart so that it's easier to see through.
It's a necessary evil of
necessary evil.
mammogram.
I'm sorry. I know. I'm
really uncomfortable.
It is super uncomfortable. It is not. No one likes it, but it is a necessary evil.
With the compression aspect, is there risk, or we didn't even talk about implants and different imaging if there are breast implants. Does that increase the risk of doing mammo if you have breast implants, or should you still do both? Is it still mammo first and then ultrasound if needed?
So the medical community is always going to recommend mammo first. There is some increased risk with breast implants, not for radiation.
Compression aspect, right?
The compression, that's right.
Yeah.
So there is a little bit of increased risk of causing the rupture of the implant is what the risk is. Implants that are behind the muscle have less risk of that with mammo than implants that are in front of the muscle. That's probably more information than anybody really wants to know, but
I think that's good information.
Just part of it. Even with the ABUS ultrasound, we do additional views when you have implants. So there is a small amount of compression, but it's not bringing the breast out and compressing. It's just kind of compressing the breast against your chest. But because the implants don't give in like normal breast tissue does, they may do a couple of extra views with the ABUS ultrasound in order to get the whole breast on when you have implants. So there is a little bit of difference in the way that they do the implants for both of those modalities. For MRI, it's not. They still just kind of put you in the thing laying face down so that everything sort of hangs low. But then you do have that aspect.
You said in MRI they have like a little indentation for your breasts to like hang down.
Yeah.
I feel like that's a genius invention. I wish they had massage tables that were like that.
I know, right? Yeah. So they do. They have this little but they do have to like make sure that they get all the way around the implant with the MRI. I mean, they can, because the MRI is circular, right? But it just takes a little bit of looking around, because you're not going to ever see through that implant with any of our imaging technologies.
Okay. Interesting. Okay. Did I forget anything? Anything you would like to share that I forgot to ask?
No, I think my last statistic to share, because I like statistics. But again, I just want women to realize that they can and should have some sort of screening done, because the statistics are still 1 in 8 women will have breast cancer in their lifetime. So I would love to see those statistics change. I would love to see that get better.
1 in 8 for a long time, hasn't it?
It has been 1 in 8 for a really long time. And, our mortality rate has gotten better. But when I was looking at some websites recently, because I deal with so many different things, I was on the World Health Organization website, and the most common cancer diagnosed in 2020 was breast cancer. So let's hope that we can do something to make that better.
Absolutely. Increase screening, but decrease finding.
Yes.
That's when we know we're winning.
That's right.
If we increase screening and increase finding, then we're glad we are finding more that we were missing before.
Yeah, we're that's right. We're still in a hole a little bit. We're still in a deficit. So
for sure.
We want to be able to figure out, what can we do to actually reduce that percentage of women who are going to have breast cancer in their lifetime. What is it that we're doing in our lives that is causing this to happen? And, whether it's hormones, like birth control pills, or, whatever, or is
never
it
just one thing? Yeah.
It's not. That's right. There are studies out there. I've been a part of a study ever since my diagnosis to hopefully try to find some reasons, looking at, things that are in our environment from our childhood on. And so, I'm still a part of that study. That study is still ongoing. So I'm hoping that they will find some answers for us, and keep that going.
All right. Well, I'm glad you are here for the girls, like here for the girls.org.
Yeah.
And we'll send everybody to that website, to densebreast.org. And thanks so much for hanging out for a little while. This was good. I think we gave the audience some good information, good tips that they can use, a good balanced view, because like everything, there is a time and a place for many, many things and different philosophies of care. And that's all okay. Like I think there's a place for all of it. Yeah. And sometimes modern problems call for modern solutions. And I think cancer is one of those more modern problems, because we do have so much more of it now than we did when we weren't living as long, and when our environment wasn't maybe quite so toxic and carcinogenic. So I think it does often call for modern solutions and modern ways of using technology to find it, and find it quick, and find it early, so we can stop it in its tracks. That's
right. It's the beast, and breast cancer is one of the worst beasts. It's sneaky. Oh my God, it's sneaky. You can go for 10, 15 years and have a recurrence, unfortunately. That was, because it's been in forefront in my mind, that was Suzanne Summers. She went for a really long time with. Yeah.
Wasn't her first diagnosis was in her 20s, I think.
Yeah. She was young, and she went for a very long time, and she did all the lifestyle changes, and she was
very holistic. Yes.
She was super holistic about her approach, and did so good for so long. But that's the sneaky beast that is breast cancer, unfortunately.
Yeah. All right. Well, thanks for hanging out.
Thank you.
We will say bye to the audience for now, and we will see you in the next episode.
Thank you, guys.
That does it for another episode of the Flourish podcast. We hope you enjoyed the show, and we'll see you next time. Bye for now.